right, everybody. This is Dr. Rayford from Vet Triage. We are continuing on with this issue of JAVMA. June 1st, 2015. The clinical effects of vinorelbine administration is a chemotherapy drug in the management of various malignant tumor types in dogs, 58 cases, 1997 to 2012. The study comes out of the University of Wisconsin and Kansas State University, both of which are veterinary schools. So I'm going to say right off the bat, this is one of my least favorite studies as far as its construct, and you'll see why. The problem with studies like this is that they're very weak, and when you have studies that get rejected by journals like JAVMA that are much better than studies like this, I question whether or not we can even trust the system anymore. So it's a fine study for what it is, I guess. I mean, let me rephrase that. It's not completely useless. That's what I mean by it's a fine study for what it is. But my opinion is there's probably other papers that got declined that were better than this one, and this one got through. Objective is to evaluate the effectiveness of vinorelbine in the management of various malignant tumors in dogs. It's retrospective, 58 animals, pulmonary carcinoma, histiocytic sarcoma, mast cell tumor, lymphoma, melanoma, and other tumor types. The results found that vinorelbine was administered palliatively to 76% of dogs. 2% had a complete response for 162 days. 11% had a partial response for a median duration of 91 days. 43% had stable disease for a median duration of 68 days. And 43% had progressive disease after a median duration of 21 days. The clinical benefit was more difficult to assess in the remaining 24% of dogs. Overall median time to tumor progression was 103 days, but ranged from 5 days to 1,533. I mean, the problem that it's such a wide range, like 5 days to 1,500 days. It's crazy, and that's because of lack of standardization in a paper like this. Introduction: vinorelbine tartrate, also known as 3'4' dihydro4'-deoxy C'-norvincalcoblastin, is a semi-synthetic derivative of the vinca alkaloid vinblastin, which is also known as 5' non-hydrovinblastin. It causes disruption of the structure and function of cellular mitotic spindles, reflected in failure of cell division at metaphase. It interferes with amino acid and protein metabolism, cyclic AMP metabolism, glutathione metabolism, calmodulin-dependent calcium transport ATPase activity, cellular respiration, nucleic acid biosynthesis, or lipid biosynthesis. Hold on one second. So various modalities, and they characterize chemotherapies by different categories. So that's just all those mechanisms are some of the ways they categorize these. In humans, a typical dose regimen for this chemotherapy as a sole treatment is 30 milligrams per meter squared, given IV weekly or every 2 weeks until tumor progression or adverse events become a concern. When the drug is administered in conjunction with cisplatin, the dose is decreased, 25 mg per meter squared, IV weekly, with the same endpoint. Weekly hematologic monitoring is required. Dose adjustments are usually made on the basis of hematologic, gastrointestinal, or hepatotoxic effects that develop. The adverse event profile of vinorelbine in humans is similar to that of other vinca alkaloids. It includes myelosuppression, which is characterized by neutropenia, gastrointestinal disease like nausea, vomiting, diarrhea, constipation, less commonly reported fatigue, alopecia, peripheral neuropathy, jaw pain, myalgia, arthralgia, hemorrhagic cystitis, and antidiuretic hormone secretion in inappropriate concentrations. Vinorelbine also causes thrombophlebitis or moderate tissue necrosis following inadvertent extravasation of the drug. Additionally, in humans undergoing radiotherapy, vinorelbine may act as a radiation sensitizer. 15 mg per meter squared can be used as a starting dose in dogs with neutropenia identified as a dose-limiting toxic effect, meaning an adverse event that most often limits additional increases in the dose of the chemotherapeutic agent. Myelosuppression was seen in 32% of dogs with grade 2 to 4 neutropenia and 21% that received the drugs over 15 mg per meter squared. In other studies, neutropenia grades 2 to 4 was seen in 38% of dogs treated with this chemo at 15 mg per meter squared, and 9% total administered doses given to 14 dogs, receiving a median of 6 doses at a median of 15 mg per meter squared. GI toxicity, 16% of dogs in another study. And then in another study, mild to moderate GI toxic effects, 46% of treated dogs, or after 49% total administered doses. A dose of 11.5 milligrams of vinorelbine per meter squared is recommended as the starting dose in cats based on a phase 1 clinical trial, with dose-limiting effects in cats including neutropenia, vomiting, and nephrotoxic. In the United States, vinorelbine has been approved by the FDA for either alone use or combination with cisplatin for humans with advanced stage non-small cell lung cancer. In other countries, drugs have been approved for treatment of advanced breast cancer. Moreover, evidence exists to support the use of vinorelbine in the management of a wide spectrum of cancers in humans, including cervical cancer, ovarian cancer, head and neck, esophageal squamous cell carcinoma, mesothelioma, multiple myeloma, Hodgkin and non-Hodgkin lymphoma, and pediatric brain tumors. Vinorelbine is considered promising for advanced stage cancers in humans previously treated with vinca alkaloids because complete cross-resistance has not been reported for either of the more commonly administered vinca alkaloids like vincristine and vinblastine. So the clinical activity of vinorelbine has been identified in several dogs with bronchoalveolar carcinoma, as well as dogs with naive mast cell disease or refractory transitional cell carcinoma of the urinary bladder. Okay, materials and methods. Dogs may have received vinorelbine as post-op adjuvant treatment when they had unappreciable or microscopically evident disease, or as palliative treatment when they had primary or progressive macroscopic evident disease. Responses of solid tumors were retrospectively evaluated in accordance with the Veterinary Cooperative Oncology Group consensus statement on response evaluation for solid tumors. And this is on the basis of absolute or diagnostic imaging, measurements of the longest tumor diameter, and variations in these measurements. To be classified as a response to the chemotherapy, changes in solid tumor size were required to have been documented for a minimum of 28 days. Responses to non-solid tumors like lymphoma, based on the Veterinary Cooperative Oncology Group, for peripheral nodal lymphoma in dogs, to be classified as a response, a change in lymph node size was required to have been maintained for at least 7 days, given that most dogs received vinorelbine once per week, and all dogs with lymphoma had advanced stage refractory disease. A clinical response was defined as resolution of all evidence of disease, with all lymph nodes considered unremarkable in size. A partial response with at least 30% decrease in the mean sum of the longest diameters of the lymph nodes, with the mean sum of the longest diameters of the lymph nodes at baseline used as reference. Progressive disease was defined at least 20% increase in the mean sum of the longest diameter of the target lymph nodes, with the mean sum of the longest diameters of target lymph nodes at baseline used as a reference, or the appearance of new lesions like liver, spleen, or bone marrow. And then stable disease was defined as any variation in lymph node size not sufficient to qualify as a partial response or progressive disease. Basically, the Veterinary Cooperative Oncology Group is meant to figure out objective ways of defining these terms, which is very useful. Results. So, median age of the dogs, 10 years. 59% were female spayed, mostly Labrador Retrievers and Labrador Retriever crosses, and 22% Golden Retrievers and their crosses, 14%, and so on. Median body weight, 28 kilograms or 61.8 pounds. The cancers, primary pulmonary carcinoma, 53%. Histiocytic sarcoma, 16%. Mast cell tumor, 9%. Lymphoma, 7%. Melanoma, 3%. And then a bunch of other cancers like apocrine gland anal sac carcinoma, mammary gland adenocarcinoma, thyroid gland carcinoma, tonsillar squamous cell carcinoma, metastatic carcinoma of unknown primary site of origin, osteosarcoma, soft tissue sarcoma. Each of those were 2%. 72% diagnoses were made on the basis of histological findings, 24% on cytology, 3% from or presumptive based on diagnostic imaging. Hold on one second. So the administration and toxicosis profile. Median dose of vinorelbine was 15 mg per meter squared. The median number of doses administered was 4, with a median cumulative dose of 78 mg per meter squared. Sorry guys, this is vet triage, is what happens. 78% of dogs received vinorelbine weekly. Vinorelbine was administered palliatively to dogs with microscopically evident disease in most situations, 76%. Neutropenia, which was reported for 40% of dogs, 14% had grade 2 neutropenia. There was no association detected between magnitude of the vinorelbine dose and the grade of neutropenia. Hold on. Okay. So vinorelbine was administered palliatively to dogs with macroscopically evident disease in most situations, was 76%. Neutropenia was seen in 40%, 14% at grade 2 neutropenia. No association between magnitude of the vinorelbine dose and the grade of neutropenia, nor was there an association between timing of the dose and the neutropenic or febrile episodes. And again, take that with a grain of salt because these numbers are not big numbers and there is no standardization in this paper. Thrombocytopenia was seen in 7%, 20% had mild GI toxic effects. Regarding overall outcome, median duration of follow-up 262 days, 76% with gross measurable disease at the time of vinorelbine administration, 2% had a complete response, 11% partial response, 43% stable disease, 43% progressive disease. Now the paper goes into breaking down by individual cancers. Primary pulmonary carcinoma, 53% had this disease. Subtypes include bronchoalveolar or bronchogenic adenocarcinoma, 3%, papillary adenocarcinoma, 23%, unclassified pulmonary carcinoma, 32%, squamous cell carcinoma, 3%, pulmonary carcinosarcoma, 3%. The median age, 11 years, 68% female spayed, 26% Labradors, mean body weight, 22 kgs. Some had surgery with or without immediate adjunctive treatment. Median time to tumor progression, 95 days. Median overall survival time, 415 days. And then the other dogs received immediate adjunctive treatment. Their time to tumor progression was 103 days. Overall survival time, 324 days. Not significant values from dogs that underwent surgery. For the dogs with macroscopic evident primary pulmonary carcinoma, vinorelbine was the primary palliative treatment. Following treatment of this, partial response, median duration 91 days, stable disease 68 days median, and progressive disease 21 days median. The median time to tumor progression and the overall survival time 55 days and 92 days respectively. Dogs with stable disease, median duration 68 days, time to tumor progression was 55 days, overall survival time 101 days. See why standardization is important. These numbers don't mean anything. It's nice to have like a sort of a roundabout idea of how these animals respond, but you can't really use it much. Next cancer is histiocytic sarcoma. Median age 7 years old, partial response 36 days, overall time to tumor progression was 771 days, And then another group of dogs, the time of tumor progression 162 days, progressive disease 50 days, median time to tumor progression 61 days, progressive disease 12 to 27 days. Mast cell tumor, median age 8.2 years, stable disease for 87 days. Multicentric lymphoma, median age 5.1 years, progressive disease 8 and 17 days later, short-lived partial response 21 days, stable disease 56 days. Other tumors, melanoma, apocrine gland anal sac adenocarcinoma, had stable disease, and then the paraneoplastic hypercalcemia resolved for 163 days. Thyroid gland carcinoma, stable disease 123 days. Mammary gland carcinoma, stable disease 109 days. Carcinoma of unknown primary site, progressive disease 29 days. Squamous cell carcinoma, progressive disease 33 days. Soft tissue sarcoma, progressive disease 28 days. Hold on one second. Carcinoma of unknown primary site, progressive disease 29 days. Squamous cell carcinoma, progressive disease 33 days. Soft tissue sarcoma, progressive disease 28 days. Osteosarcoma, progressive disease 21 days. Discussion. Findings of this study support the pre-existing hypothesis that vinorelbine has clinical activity against primary lung tumors in dogs. Bronchoalveolar carcinoma, a partial response was identified in 2 dogs, stable disease as well. Also in this study, partial response of pulmonary carcinoma, stable disease as well. Median overall survival time 324 days, which is comparable to survivals of 106, 361, and 120 days in other studies with primary pulmonary neoplasia that were treated with surgery alone without adjunctive treatment with vinorelbine. With histiocytic sarcoma in a previous study, overall response rate 46% treated with lomustine, with 54% living over 7 days following the first treatment, achieving a partial or complete response. The median time to tumor progression in that study was 85 days. The median overall survival time was 172 days. A longer median overall survival time, 568 days, has been reported for dogs with appendicular histiocytic sarcoma managed with aggressive multimodal treatment approach. In this study, complete response with vinorelbine was identified in 1 dog with metastatic splenic histiocytic sarcoma. Time to tumor progression 162 days. Overall survival time 277 days. And then another study, time to tumor progression 771 days. Overall survival time 1,264 days. Cutaneous mast cell tumor, overall response 13%. Given a 20% response rate for palliative administration, they suggest in this study that vinorelbine might be considered a reasonable rescue agent for mast cell disease in dogs that are unresponsive to preferred first-line chemotherapeutic agents such as vinblastine and tocorinib phosphate. Multicentric lymphoma had a partial response of 21 days, stable disease of 56 days, stable disease, again, 56 days. Neutropenia developed in 40% of dogs in the present study compared with 54% of dogs in another study and 21% and after 21% doses in another study. 7% of dogs developed clinically irrelevant thrombocytopenia in this study, which seemed to worsen with increasing number of doses of vinorelbine. 21% of dogs had mild GI upset after receiving vinorelbine. So the problem with this study, they mentioned here, it's retrospective, so there's no standardization because of that, and every case is treated differently because of that. There's no standardized procedures, there's no exclusion criteria. The data generated in this study would therefore rank low in the hierarchy of evidence quality used in evidence-based medicine. I mean, how dumb? Then why publish it? Why publish it? There are so many other papers that probably got pushed aside because of this one. Anyway, this study supports the previous recommendation by other investigators that 15 milligrams of vinorelbine per meter squared can be used as a starting dose and then tailoring the dose to minimize adverse effects and maximize efficacy. The Drug had ostensible anti-neoplastic activity in the treatment of several tumor histologic subtypes, including pulmonary carcinoma, histiocytic sarcoma, lymphoma, mast cell disease, and transitional cell carcinoma of the urinary bladder. There you go. You know my thoughts. I guess for veterinarians, just take studies like this with a grain of salt. And most vets are not performing chemotherapy anyway, especially cutting edge chemotherapy like newer drugs. This is mostly for oncologists, and they're of course going to be very familiar with studies like this. And then for pet owners, when you hear new drugs, just again be skeptical, because chances are there's way more work that has to be done before considering something a miracle cure. They were not claiming that here, but just be aware that studies like this exist, and you can't always go base your own research when trying to talk to an oncologist, because studies like this have weaknesses even though they are published in a reputable journal. All right, we'll see you again in the next video. Thanks, guys.